Welcome to the SJMC Grand Rounds, where our experts come together and discuss challenging cases. Witness a synergy of intellect and medical expertise as we embark on our continuing medical education journey together. Before we start, I would like to remind you to subscribe to our channel and enable notifications so as not to miss our upcoming episodes. Now let's begin.
Hello and welcome everyone to another episode of our SJMC Grand Rounds. This is the Cardiology Grand Round number 38. And with me are my esteemed cardiology colleagues, Dr. Jayamala, who is actually in the same virtual studio as I am, Dr. Kanan, and Dr. Navin. So, hi guys. So today the topic is on pulmonary embolism and under-recognized problems. So I think this is going to be a very important case presentation and discussion around it. But before we move on to the actual meat of the presentation, just let me go through some housekeeping slides. Please subscribe so that you can stay informed of our upcoming webinars. We are going to use, as usual, Slido for the comments, yeah? And the Slido code is 33718671. You can enter that at slido.com, or you have the Slido app installed in your mobile phone. You can enter that code and it will take you to the event discussion. Just before we start, we want to put an ad for the cardiology symposium, which will be next year, and next year is only next month on the 12th of January 2025. It will be held at the Dorset Grand in Subang Jaya. And here are our esteemed speakers. This is last year's, or rather this year's one was a huge success. So we hope that the same thing would be repeated for the, mainly targeted at general practitioners and family physicians. And this is the invitation to register. So if you can scan this with your QR code scanner, it will take you to the registration link for the cardiology symposium. So the CBD points would be for this event, for our today's event will be presented later. So I think without further ado, I think we shall start with the grand round. So I invite the chairperson, Dr. Jayamala, to proceed. So over to you, Jayamala.
Thank you very much, Alan. As you mentioned, this is our 38th grand round, and we are going to talk about pulmonary embolism, the diagnostic dilemmas, and the therapeutic options that are available today. There are 4 cases, and the first case is mine. It's a previously healthy man, no previous significant medical illnesses, plays badminton regularly. On that particular day, at about 8 p.m., that means after dinner, while playing badminton and bending down to pick up the shuttlecock, he suddenly fell with loss of consciousness. He was noted to be stiff all over. He was playing with a few friends who happened to be medical doctors, and they apparently felt a good, strong pulse, but he was not with it. They called the ambulance and brought him to ER. He was a non-smoker. In ER, he was awake, but completely amnesic of what happened. No chest pain, headache, cough. They had a sinus tachycardia, 133, and the BP is as shown. Oxygen saturation was 100% on room air, and the examination was otherwise unremarkable. The urgent CT scan of the head was normal. This was to exclude an intracerebral bleed. Okay, so the first question to Kanan: when someone faints on a badminton or tennis court, what are the common causes, Kanan?
I suppose if you're going to talk with regards to this particular patient, This is somebody who had been active and mobile. He had collapsed suddenly, and the relevant things are his pulse was felt, his blood pressure is now high, he's been found to have fast pulse, and his saturation is good at 100% on room air. And whatever examination has been done, the heart and lungs are normal. So the things that would start off is probably I think about something neurological, maybe at a seizure, or it could be a transient ischemic attack. I think instead of not finding any cardiac signs, I'm still worried about a cardiovascular problem. This could be a very transient, severe arrhythmia, like he could have had a ventricular tachycardia, which has since reverted. Sick sinus syndrome is also something that you can consider. He could have had a long pause that caused him to faint, and both of these would have underlying coronary artery disease as the most common etiology. Other things would be things like obstructive lesions, like hypertrophic cardiomyopathy, could be a relatively silent heart. Of course, if he has got aortic stenosis, one would have expected to hear a murmur, but that can also cause someone to collapse. This could be dehydration. Because playing badminton, maybe played too hard, lost too much volume, BP dropped. Hypoglycemia for whatever reason, in case he was on medication for it. Those are things I'll think about.
What test would you do?
Okay, so all of them, I think we want an ECG first, get a chest X-ray, and quickly pull an echo machine, do an echocardiogram. Then there are various bloods to run, hemoglobin, electrolytes. Obviously, you want to do, most times you'll have a troponin T done, but you must remember that this is very early into the onset of symptoms, so it could be negative. And CT brain was already done and it's normal.
This was the ECG that was requested by Kannan. And Dr. Navin, can you sort of just tell us what your thoughts?
Okay, so from this ECG, we can see that he is in sinus rhythm. Tachycardic, as what was evidenced by the physical examination, heart rate is about 140 to 150 beats per minute from the ECG. The axis is normal. I don't see very significant ST changes or T wave changes. One would argue is that Q waves in the inferior lead, maybe especially in lead 3 with some inverted T waves there. That's about it. Otherwise, it's fairly non-specific changes. Say.
This was the ECG on day 1 and this was ECG on day 2.
Yeah, I mean, even the ECG day 2, you don't see much. Now, he's definitely not as tachycardic as he was. But besides that, I don't see any new changes. Those Q waves there are still more or less the same in lead 3.
So not really very helpful.
Yeah.
So the blood test, hemoglobin, okay. Sugar, 6. This was at the time when he came, but his HbA1c of 5.7. Lipids well controlled. In ER, they did the TROP-T and the CKMB, and that is 241 and 2.9. So what's the significance of raised troponin in this patient, Dr. Navin? And the next question is also yours.
Okay. Well, I mean, the raised troponin could, and with his clinical presentation, could indicate that he had suffered a cardiac event. A non-ST elevation MI or unstable. I mean, I would say a non-ST elevation MI because there's no significant ST changes here. Sometimes you can even get it due to other reasons, myocardial ischemia or myocardial necrosis, such as pulmonary embolism. If the RV or RA is dilated, that can also cause. So I think this will sort of narrow down our working diagnosis at the moment. And if you are talking about a way to distinguish whether troponin is due to a chronic condition and due to acute cardiac injury, I think one way is actually to do serial troponins and see how much is the rise. If there is a rise of more than 20 to 30%, then probably that is significant. If it's due to chronic conditions, we do see raised troponin due to sepsis, due to renal impairment, and that will usually remain fairly plateau.
This man has also just been exercising, so sometimes that too may have caused the troponin T to be raised. But so these were some of the things which are going through the mind. And as you mentioned, the troponins were, and the CKMB was repeated on the following day, and there seems to be a change in troponin T coming down and the CKMB going up. But again, may or may not be significant when somebody who had just exercised. Chest X-ray normal, echocardiogram done normal. He was actually admitted under the neurologist as query fits. This was late in the night, and this was about, almost by the time he got admitted, about 11 o'clock. So in CCU, he was comfortable, he had no pains, no arrhythmias, and throughout the night, the oxygen saturation was 98 to 100% on room air. Okay, so what are your thoughts now, Kanan, and how would you manage this patient?
I would, if the neuro people have excluded something important, I think we have already gone through the history and physical examination. So we'll go look back at the ECG. ECG showed tachycardia. Someone comes in, collapse, they're tachycardic. A few things we want to look for. We look for ischemic features, which we could not find anything in this man. We look for structural abnormalities in the heart. We did not find anything in this man. We look for conduction problems. We did not find anything in this man. So if you are still tachycardic, and I think one of the things we look scrutinize carefully in the ECG is always think about pulmonary embolism. And I think in the ECG that Navin interpreted, we could make out S1 Q3 T3. You can see that there. It's a very non-specific sign, but something to think about. So I would still search for coronary artery disease because there's some change in the troponin, some change in the CKMB. So I think I'll ask for a CT coronary angiogram. That's what I want to do.
Okay, actually, what I did was I thought it was diagnosis initial was we need to rule out a non-STEMI, and he was actually planned for an invasive coronary angiogram. But as luck would have it, the angio suite was quite packed that day. So I said, okay, we will do a CT first. So a CT was done. And Kanan, would you like to interpret this CT?
Yeah. So this obviously shows this when we do a CT angiogram, most of the times we are focusing on the coronary arteries. I think Dr. Yap, during one of our presentations, reminded us that as we screen through, we want to look at the proximal pulmonary arteries. And in this man, we can obviously see there, put the pointer, you can see filling defects in the pulmonary artery. And this tells us this pulmonary embolism. So, I mean, to be very honest, if I was to go through the presentation as Jaya put it, I would have ordered a CT angiogram, maybe to look at the coronary arteries. But all of us have learned to look at the proximal pulmonary arteries as we look at a scan, and here the diagnosis is evident that this is pulmonary embolism.
So, how would you now manage this patient, Kanan?
Okay, so a few things have been done. Obviously, we will consider him as low risk pulmonary embolism. Low risk because he's hemodynamically stable, low risk because his saturation is normal and his heart rate is also settled. So first, we have considered treatment for him. We want to start him on heparin as soon as is possible. And then we have to investigate to find out why did he develop pulmonary embolism. We want to find the source. So the sources would be, we want to do a Doppler examination of the calves, his legs. We want to do a CT examination of his abdomen to see whether there are any thrombi there, or is there any evidence of any malignancy that's causing it. And then we want to do some blood investigations to look for hypercoagulopathies as the cause of this pulmonary embolism.
Okay, we did what was said. We had venous thrombosis seen in the left lower limb calf veins. But again, why should he get a thrombotic occlusion or a DVT? And of course, refer to the hematologist who ordered all these tests, and it turned out that he was lupus anticoagulant was strongly positive. He probably had a anti-phospholipid syndrome, and that's when a great Dr. Allen was called in. So he remained well throughout. He was started on with low molecular weight heparin, as Kanan pointed out, and then switched to NOAC. But when the anti-phospholipid titers came back, he was switched to warfarin. Warfarin is more superior in this case rather than NOAC. Okay, we should just move on to the next case, diagnosis massive pulmonary embolism. The next case is another lady, 46 years old, and she came in with a one-day history or feeling weak and lethargic, having some shortness of breath and wheezing. Poor appetite. She had woken up to go to the toilet at about 3 a.m. in the morning and then she had fainted, but there was no loss of consciousness. There was no fever or cough, and she had actually been working as a clerk up to the previous day. Past medical history, she had AVRT when had an RFA done in 2010, lateral meniscus tear 2019, hemorrhoidectomy 2024, diabetes on diet control, hypertension and hypercholesterolemia on export and Lipitor. So when she came to ER, she was awake, heart rate was fast, BP was as shown, oxygen saturation was about 94 to 95% on room air, dual rhythm, her lungs, she had occasional bronchi. Okay, so if you saw this patient in ER, what would you do, Navin?
I think the initial assessment has already been done. Probably even just get a look at the JVP if that's possible, see if it's raised as well, because one of the working diagnoses can actually be some form of decompensated heart failure, or she could be having pneumonia or something like that. So the next thing, I'll probably order a few tests, some bloods, chest X-ray and ECG as well.
Okay, these are the results of the test which were done. Hemoglobin is a little bit low. She had a leukocytosis where 90% of it was neutrophils. HbA1c, CRP was elevated at 24.1. And again, troponin T, CKMB, as well as NT-proBNP was elevated. So there was a big fight at that time, whether it's respiratory physician or whether it should be the cardiologist. So ding dong, ding dong, ding dong, as usual. But since the troponin T was raised, the cardiologist was called in. Okay, this was the ECG, and Navin, can you interpret it? Because this was an ECG. This was the ECG you had reported in April, and this is a present ECG.
So at a quick glance, the April one looked perfectly normal. But if you compare, there are some new changes here. So again, if you look, she's in sinus rhythm. Tachycardic, the rate is about 140, 150. Now, what I see is Q waves in the inferior lead, some T inversion there, but there are some new T wave inversions in V1 up to V3 with a poor R wave progression. So this could again indicate a cardiac event, heart failure. Pulmonary embolism is something that we should be thinking about as well.
Okay, I think the working diagnosis that night for the cardiologist was whether this was a non-STEMI, maybe leading to a bit of heart failure. But the cardiologist was a bit hardworking. Chest X-ray was normal. He did an echo. And would you like to interpret this echo, Kanan?
It's very obvious that the chambers on the left are very dilated. This is
right chambers.
Yeah, that's left. So yeah, these are the right chambers. I'm saying the left of the image. Okay, and when you see huge chambers like this, then you worry about whether this is severe lung disease, or in a young person like this, a lady, immediately with this presentation, you start thinking about pulmonary embolism. And it must be very big embolism, because you can see that little thing in between, which is the interventricular septum, and pushed into the left ventricle. That tells you that the right ventricle is really overloaded. The right ventricle is actually very distended. It's not contracting as well as the left ventricle, as you can see.
Okay, so a CT angiogram. Kanan, can you interpret this CT angiogram?
Again, you can see the arrows, they point to filling defects within the pulmonary arteries, and this is pulmonary embolism.
So actually there was multiple segmental thrombi on both sides. The main pulmonary artery was actually quite free. Okay, so they went again to find out why. Why did this young lady who was working up to the nape before, why did she come up with a massive pulmonary embolism? Well, they ran through all the lupus anticoagulant and all those things which were negative. but the CA125 and the CA19.9 was significantly elevated. The CT scan showed a large ovarian mass. So it was pulmonary embolism secondary to disseminated carcinoma. Now, when the diagnosis was made, she started on low molecular weight, an IVC filter was inserted. Maybe Ellen, can I just ask you, why would they have inserted an IVC filter? Was it necessary?
Hi. Sorry, I was distracted by a phone call just now. Generally, filters should be put in when there is a contraindication to anticoagulation, or when anticoagulation is deemed to be not suitable, or maybe even not working. So I think in this case, I'm not so sure.
She had disseminated, she had carcinoma of ovary, so maybe because it was going to start on chemotherapy, so maybe that's why they decided to put an IVC filter.
Maybe if you're on chemo, your platelets drop, or there may be interruption in the anticoagulation. That might be
some reasons.
Utility.
Okay, so when they were going to put in, they did an IVC venogram, and looks like the left iliac vein was full of clots. Right, so there's quite a lot of clots. So she's presently on chemotherapy. When would you, now there seems a lot of talk that you want to remove IVC filters. Maybe you could share with us.
When the indication is put in where, for example, you can't anticoagulate, when the risk of thrombosis is over, let's say the cancer has been treated and there's no more. I think there is actually a concern if you leave it too long. There could be further worsening of thrombosis, and the filter should be removed as far as possible. There was a recent study which showed this, but and there's always a concern if you wait too long, it'll be very difficult to remove. And the study showed even later on you still can remove. I think you have to balance the risks of this versus not removing.
I think if I have to add on, IVC filter will also be indicated in this patient because the thrombus is actually very proximal and the iliofemoral segment. So you always worry about propagation of the clots and all that. Whereas if it's below knee, then probably you can still treat it medically.
The higher up the filter, also there's always a risk of migration of the filter.
Correct.
So it's always a concern. So I think generally they would like us to remove it within about 3 months. I think if you want to remove at all.
If I can add this IVC filter thingy, two things. One, we must mention, especially for those of us who are not familiar, the purpose of the IVC filter is to prevent further emboli going into the lungs. It does not get rid of the thrombus load. That's one. Secondly, leaving IVC filters. In the old days, they used to have permanent filters and removable filters. And those who had permanent filters, the incidence of deep vein thrombosis in the lower limbs increases. So that's another reason why we want to have it removed.
Okay, the next case is a Kanan's case.
Do you think the management of this case is worth discussing a bit more, because the ball game here is quite different from the first case?
Okay, the reason why they started off this with the low molecular weight heparin was because there was already multiple in both arteries. So they started off with Plexane from the word go, and in fact, later they switched to the nothing.
I'm just thinking that suppose, I mean, this is quite massive in the sense that your cardiac biomarkers are markedly changed, the RV dysfunction is there. The thing and she's very desaturated. The thing that's going for her is the pressure is maintained. So it means that there's enough perfusion going. But let's say that, through the night it gets worse. What options are open to you? You can't use thrombolytics because she's got a big ovarian tumor. So what options are open to you for treatment? I think it's worth discussing here.
I think we'll discuss that.
We discuss all the cases, and then we can come back to this later. Okay, Kanan, your case.
All right, so this is somebody from our archives, okay? When Jaya mentioned about this, I remember this man. So some of the data is no longer available because they were seen more than 15 years ago. 28 years old, He was brought to our emergency room, complaining of sudden breathlessness at home. Blood pressure on arrival in our emergency room was low, 80/70. He was tachycardic at 140 per minute. Afebrile, respiratory rate was raised, no pallor. Heart, in the left parasternal edge, you could hear an S4 as well as a short systolic murmur. The lungs were clear, critically abdomen, nothing much to find. But when we examined him, we noticed that he had a left knee brace in place. So I wanted to tickle Navin. What would you do today? What's the differential diagnosis to consider? What investigations would you do? And what treatment would you initiate?
I mean, looking at this patient is hemodynamically unstable, right? The saturations were low as well, right? Yeah. So I know a knee brace indicates that he's been probably immobile for quite some time. So a young guy, no other risk factors. First thing on my mind would be pulmonary embolism. I would also consider some form of cardiac event as well. You see patients coming in younger and younger these days with acute coronary syndrome. So that will be another differential. Investigations, I think he would require an ECG first and foremost, an ECG which will give us an idea. Some blood tests to be done, chest X-ray as well. What treatment would you initiate immediately? I mean, I have high suspicion of pulmonary embolism, so I wouldn't hesitate to start him on heparin, either low molecular weight or unfractionated heparin.
I suppose nowadays we'll just pull the echo machine. Often
yes,
gives us a
correct.
lot of clues, isn't it?
Yeah, just a bedside echo will tell us a lot.
Yes, stepped out. Can somebody change the next slide? Okay. So this is the things that we thought we would do. We try to get more history from the patient, get a venous access because obviously he's very ill, send blood for investigations. BP is low, so we'll run some IV fluids, and if that doesn't settle the hemodynamics, we'll start the patient on inotropes. We want to get a chest X-ray and an ECG done, and like we said, we'll pull the echo machine and do a quick echocardiogram. Next slide, please. So we got more history from the patient, from the relatives rather. He was very sick. So this was a football player, non-smoker, not known to have any medical illnesses, so very active person. Next, please. 2 weeks earlier, he had sprained his left knee, so he was put on braces for this. He had not played any games and physical activities were limited. Next, please. So 1 week ago, he had developed mild breathlessness on exertion. Next. And then after using the toilet in the morning of admission, he had suddenly become very breathless. Next. She did not complain of any chest pain. He had no history to suggest an infective illness, and she was brought to ER by the family, and he had to be carried in because he was very unwell. Next, please.
Okay.
This was his ECG.
Yeah. Basically, the ECG shows he had sinus tachycardia. Axis is normal. I think if you really want to stretch it, you can say maybe he had an S1, Q3, T3, but there was no RV strain pattern.
Next, please. So we did his X-ray, and this is his echocardiogram still frames. So Navin, you want to comment first?
Okay, the chest X-ray, you can see there is lung fields are fairly clear. There is some increase in the pulmonary vasculature. You can see the heart is not enlarged. Don't think so. There is a pleural effusion as well. I don't see any signs of any pneumothorax, which is probably something else that we have to think about in a young guy who presents in such a manner. If you look at the echocardiogram, the pointer is over the right chambers of the heart, right on the left side of the image, and you can see that the right atrium and the right ventricle is grossly dilated. So definitely the ratio of the RV to the LV is more than 0.9 or more than 1. So that indicates there is increased pressure in the lung that is actually leading to this. So again, this supports the diagnosis of pulmonary embolism, massive pulmonary embolism.
Yes, the echo slide for the general practitioners often ring us to ask about the pictures that we showed. Can you just show us where the left ventricle is there? So that's the left ventricle that they are showing. And for those of us not familiar with the echo, you realize that it looks like so much smaller than the right. Usually the The left ventricle is the same size, not a little bigger than the right. So this is very big overload of the right. Next, please.
Yeah.
Okay, so progress.
talk to
The
you.
patient is on EVO for oxygenation. He's still very breathless. BP is 90/70 or noradrenaline. Next, please. So Naveen, what would you do?
So he's still very breathless. He's probably, we need to activate, we get our anesthetist in as well, get some help and try to stabilize him. He may require ventilation. BP he's still hypotensive. So probably need to run some fluids and also increase the inotropic support. And I will probably even start him on Clexane immediately.
You already started happening earlier, then you're very suspicious. Okay, all right. And then what happened? I had to look through the notes to remind myself. So his BP started to crash, so they had to call. They had to call a code. The anesthetist was already there. He was intubated. Next slide, please. Then the diagnosis of pulmonary embolism was made clinically based on his presentation. So we actually gave him intravenous tissue plasminogen activator, which is a thrombolytic. And following the old regime, this was infused intravenously over 2 hours. Next. A CT scan was done soon after. It is confirmed large pulmonary emboli. Next, please. His hemodynamics slowly improved, and the next day he could be extubated. And Jaya will talk to us about the CT.
Okay, again, you see the same thing. This is the main pulmonary artery, and you can see there's a filling defect here and another large filling defect here. So again, a large pulmonary emboli to confirming the clinical diagnosis.
So I want to ask Naveen. I mean, this was someone we managed more than 15 years ago, and using thrombolytics really was considered very revolutionary as compared to heparin. This was somebody with severe pulmonary embolism. Certainly, it was an indication to use then as it will be today. Will you manage anything differently in 2024?
So you're very right in saying that, Dr. Kannan. I mean, even today, if you go by the evidence, it's a class 1 indication in such a patient with high-risk massive pulmonary embolism with hemodynamic instability to actually use systemic thrombolysis. But of course, it's not without its pros and cons. So now we do have some new tools in our arsenal. So probably I can, it's called catheter-based therapies, where I will share more when I present my case.
The only thing is, I guess this man was so sick, he probably will not be in a state to move him anywhere around. So I guess the only thing that you have is you have to probably do it there and then, because it was already code blue. So you're probably not in a position to.
So you couldn't even do a CTPA before you administered the medication.
Okay, so we come on to the last case, which is by Dr. Naveen.
Okay, so mine is a 48-year-old Egyptian male. Very interesting. He's a medical doctor. So he was actually part of the team that came to set up our EMR, our electronic medical records in SJMC. So background history of paraganglionoma, resection done 2 years ago, and subsequently he had hepatic vein thrombosis. So he was on anticoagulation for a few months, and that was stopped. And it was actually thought that the hepatic vein thrombosis was as a sequelae of the paraganglionoma that he had. He had it resected and so on. So he was not on long-term anticoagulation. So first time in Malaysia, arrived from Egypt, transiting in Saudi. Total flight was about 10 hours. Developed chest tightness and shortness of breath on the day of arrival, but put it down to humidity. Shortness of breath worsened with palpitation, and he came to our emergency department 2 days later. He's a non-smoker. On examination, normotensive, tachycardic. He was tachypneic as well. Respiratory rate was about 22 breaths per minute. CVS, dual rhythm, no murmur. Lungs were clear. JVP was mildly raised, and his saturations were low under room air, about 91%. Okay, Dr. Kannan, would you like to comment on the ECG?
Okay, again, this shows sinus tachycardia, is ECG. And I'm looking very hard because the way he presents his long flight and his symptoms, I'm thinking very hard about pulmonary embolism already. So I'm looking for ECG features which are usually very non-specific. I thought I could make out an S1, 2, 3, 3.
Retrospectively, always see it.
Looking very high. Yeah.
Okay. Of
Dr.
course,
Jaya,
the
any
next thing would be
thoughts
to do an echocardiogram because that's what you suspect. So yes, the echo was done.
Yeah, so I got a short axis and a 4-chamber view.
You would like to comment something about your... Obviously, the right-sided chamber is grossly enlarged,
dilated, yeah.
and you can see that the LV, which should be round, actually is the IBS is flat, which indicates that the right-sided pressure is actually very high. And this is the 4-chamber, and you can also see the same thing that we had seen earlier, that the right-sided chamber is high, and when it's going, you can see the IBS motion, which indicates that it is a very high right-sided pressure.
Dr. Kannan, any specific blood tests you would like to carry out and why?
Okay. Usually we'll do the troponins and we'll do the anti-proBNP because when we risk stratify people with pulmonary embolism, the biomarkers help us stratify them into low risk and high risk groups. So if your biomarkers are elevated and move up the scale to being higher risk, it also help you decide management.
Okay, so this is the blood test. The proBNP was within the normal range, but the troponin was elevated.
I must say I'm very surprised by your proBNP. With the right side being so dilated, I would have expected your proBNP to be far higher and definitely elevated.
We get the proBNP elevated for various reasons, but somehow in this patient, the proBNP was... Yeah, so Dr. Kannan, patient is stable hemodynamically. What diagnostic tests would confirm the diagnosis?
Severe CT, pulmonary angiogram.
Okay, so this is a movie. Okay, to pause it. Yeah, so you can rightly see, so sorry, it's moving picture. So, but you could see earlier, Dr. Jaya could just pause it. You do see filling defects bilaterally, right? Both right and left pulmonary arteries. And you can also see that the right ventricle is actually grossly dilated here. You can see it on the CT as well.
Point out there,
Yeah.
the right ventricle.
Yeah. These are all the right-sided
Right side of the chamber.
Which are dilated.
Okay, if you go to the next.
All right. So this
Okay,
is
so
a
these
still.
are some stills that are showing those filling defects as well. You can see on both sides pulmonary artery. You can actually see. So this is a massive pulmonary embolism. So the CTPA was actually reported as massive pulmonary embolism with right ventricular dysfunction. Next slide. So how would you manage this patient, Dr. Kannan?
Okay, so this is someone who has got massive pulmonary embolism. His blood pressure is maintained. His saturation is decreased. Certainly, we would want to start him on heparin. And then if I'm going to give him heparin, I'll watch him very closely. If there's any change in hemodynamics, then I'll use a thrombolytic agent. And of course, later we have to investigate to see why he developed pulmonary embolism. But obviously, the reason seems to be quite clear that this long journey and stasis would have caused it.
Okay, so I'll just go through briefly on the treatment approach for acute case of pulmonary embolism. So of course, if the patient is unstable, like Dr. Kannan's patient earlier, he may require inotropic support. In some centers, they actually use this extracorporeal membrane oxygenation called ECMO. Anticoagulation to prevent or recurrence and progression of the disease. Low molecular or unfractionated heparin, we tend to use more of low molecular weight these days. And if you're talking about reperfusion of pulmonary artery, of course, you have systemic thrombolysis, as Dr. Kannan shared earlier, catheter-directed thrombolysis, which is the new tool that we use in certain patients, and surgical embolectomy in certain cases, right? Okay, so thrombolytic therapy does lead to faster improvement in pulmonary obstruction in PE patients compared with unfractionated heparin alone. And you can actually see these changes, when you start them on treatment, you can see a reduction in their RV volume on echo. And the greatest benefit is observed when treatment is initiated within 48 hours of symptoms onset. But thrombolysis can still be useful in patients who have had symptoms up to 2 weeks. Okay, so when you talk about systemic thrombolysis, the dosage is definitely much higher, the dosage of thrombolytic agents that you'll be using, whether it's RTPase or thrombokinase, streptokinase or urokinase. And so invariably, when the dosage is higher, there's a higher risk of bleeding. And also sometimes you're worried about the effectiveness, how long does it take? When we talk about catheter-directed therapy, it allows greater surface of thrombus to be in contact with the thrombolytic agent, direct delivery, because the catheter would be put into the pulmonary arteries and we infuse the thrombolytic agent. And by doing that, we can also use much lower doses of thrombolytic agent as compared to systemic thrombolysis. So that's what we did for this patient, something we call ECOS. So how it's done is it requires a double puncture of the femoral vein. We put in catheters right up to the pulmonary artery. We take a shot, we actually establish how extensive the clot burden is. Although it's already seen on the CTPA, since we're there, we'll just take a picture. And because sometimes after this therapy, we may repeat the shots and we can actually see how the pictures look before and after. Okay, and then we put in what we call the ECOS catheter, which I'll show you later. And the thing is, we can actually measure the pulmonary artery pressure. So you can see for this patient, the mean pressure is about 40, and a normal mean pressure should be about 9 to 18 millimeters mercury, right? So the rest of it's a little clinical. So how it's done is we'll place the catheter there, and the catheter actually has two components. One of it actually emits an ultrasonic wave, which breaks down the fibrin, so that the thrombolytic agents which we infuse will work better and dissolve the clots. So there are a few studies to indicate what is the dosage that we use, right? So for this patient, I actually infuse the alteplase at 1 mg per hour through each catheter. So a total of actually over 12 hours, 24 mgs. As compared to thrombolytic agent, if you're giving systemic thrombolysis, the dosage that Dr. Kannan used, I believe, was 100 mg, right? So this is just about 1/3. So we run it for about 12 hours. And how do we assess the next day whether the treatment has been effective or not? Some centers will repeat the pulmonary angiogram, but I think all we need to do actually is just a simple echo, a bedside echo. And that's what I did for this patient. And by doing the echo, we can actually see that the RV size has actually improved. And that will tell us whether we need to continue the infusion or can we just stop the treatment and remove the catheters. So this is a pulmonary angiogram, a diagnostic shot. We can actually see, yeah, those are the filling defects, right, on the left side. And this is the diagnostic shot on the right side, the next video. So as evidenced by the pulmonary CTPA earlier, you can see those filling defects very clearly, right? Extensive thrombus burden bilaterally. Next slide. So this is how the ECOS catheters look like, right? As you can see, the first catheter that we put in is the one that will actually release the thrombolytic agent. And these dotted lines you see, those are actually the ultrasonic emitters. So these ultrasonic emitters will actually break down the fibrin so the thrombolytic agents can work in a better manner. So in patients who have only unilateral pulmonary embolism, then just one catheter. But in this patient, it's bilateral, so there are two catheters. So if you remember the echo images prior to the procedure where the RV and RA was grossly dilated, you can see the echo bedside post-procedure, the RV has actually, the size has normalized, the RA as well. And you can see the LV is definitely bigger, right? And the other thing you can do is, with the catheter in place, you can actually also measure the pulmonary artery pressures. I did not share that, but the pulmonary artery pressures in this patient actually had normalized after 12 hours. So that tells us that, most of the thrombus has actually been dissolved. The treatment has worked and we can remove the catheters and just continue with oral anticoagulation after that. Next slide. Yeah, so these are some of the studies I mentioned earlier. So take-home message, maybe, Dr. Yeah.
All right, so just a few take-home messages. As these 4 cases seems to illustrate, sometimes it's very easy, sometimes it's difficult. Can be a bit of a diagnostic challenge, but it should always be suspected in a person who suddenly has faints or near faints or presents with what looks like seizures, especially as an elderly, middle-aged to elderly person. Sudden onset shortness of breath or wheezing. Of course, it may also be due to LV failure. Pleuritic chest pain, hemoptysis, delirium in the elderly, or occasionally, like our second patient, fever and cough. Resting hypoxia, it's like we saw in the first patient, is not always present. In the second and third and fourth case, it was present. Even in the second case, it was sort of borderline. A common symptom you see across all cases is that was resting tachycardia. And the classical ECG changes of S1, Q3, T3, right axis deviation, RV strain is often not present. The most common sign is just tachycardia and non-specific STT changes. Having made the diagnosis, probably the most useful will be a simple bedside echocardiogram, which for the case 2, 3, and 4 were very helpful. Once the diagnosis is made, you need to determine the cause and treat not only of course, before we talk, once you've determined the cause, you need to risk stratify because that will help with management. High risk, intermediate, or low risk, depending on whether they are symptomatic, whether there's RV dysfunction, cardiac biomarkers are raised, or whether they are hemodynamically unstable. And start full anticoagulation. And depending on whether it is high risk, intermediate risk, or low risk, you may just want to leave with heparin or consider, especially in high risk or intermediate high risk patients, you may want to consider thrombolysis or catheter-directed thrombolysis. And of course, long-term, warfarin. Coming back to the question I was asked earlier, I think that Kanan had asked, with my patient, that second case, I mean, it was not my case, it was somebody else's case. The second case, if she did not respond to treatment, she remained hypoxic. I think one alternative would be a catheter-directed thrombolysis because she had already been started on Clexane, and you worry about bleeding because of the presence of the cancer.
So can I just add on, Jaya?
Yes,
for catheter-directed therapy, there is actually two forms of it. One is where we actually inject the thrombolytic agent, like what I shared earlier. There's another one where we do catheter-directed thrombectomy called Penumbra. So there are some patients who may have contraindication to thrombolytic agents, recent surgery, intracranial bleed, on anticoagulation. So those kind of patients may actually benefit from catheter-directed thrombectomy. And also for patients who are hemodynamically unstable, so you need to remove the clot as soon as possible, then catheter-directed thrombectomy will be another option as well.
I think maybe this slide is redundant. I think Jaya has talked about. I wanted to just highlight, if you are a frontliner, some of the points that you want to consider in a patient where you're worried about pulmonary embolism. So if you have got any symptoms suggestive of deep vein thrombosis, if there's a tachycardia, if there's any history of immobilization for any period of time, previous history of deep vein thrombosis, if the patient presents with the hemoptysis, any history of malignancy. These are things in both the Geneva score as well as the Wells score. Both of them are synonymous in mentioning this as important points, which will cause you to think about pulmonary embolism. The next slide is actually for frontliners. This is rule-out criteria in a population where the risk of pulmonary embolism is considered low. You can't use this criteria if you are seeing hospital patients where the risk of pulmonary embolism is someone who presents with breathlessness, tachycardia is high. So the points are, we can go through there. Okay, so if you have all these points, and say you're a frontliner, someone walks in and talks about feeling a bit breathless. So the age is young, the heart rate is low, the saturation is normal, there's no history of hemoptysis, there's no history of estrogen use, no prior history of deep vein thrombosis, current or past, though there's no evidence of leg swelling, and there's no surgery or trauma requiring immobilization for any period of time. If you have all of this, then you can quite safely exclude pulmonary embolism. And this criteria was made up for patients who come to ER, walk into ER, not for high-risk patients.
Okay.
And
Only valid. Not valid on clinical suspicion.
Yeah, if your clinical suspicion is high, like you can't use this for hospitalization.
Thank you.
Shall we go on to the Q&A?
Yes, please.
So there are some appearing in the Slido now. Can we see that? What happened? Right. Okay, so first two questions come from Dr. Keshav. I think the question is referring to the first case. The one playing badminton and then developed PE. BP was high on admission, but is this significant in the light of his tachycardia?
I mean, yes, it is still significant. So that because the BP was high and he had a fall, the first thing they thought about was whether he had an intracerebral bleed. So that's why a urgent CT scan was done. He was subsequently started on antihypertensive, and the BP came down for the night.
And the second question, this is the one.
Okay,
Very important question, yes.
How long would you continue this warfarin in this first patient? Now, I think this is something I should pass to Ellen, because Ellen is the one managing this patient now.
Yeah, I think this is a very important question, and there are two things here to consider. One is he had an underlying problem, which was antiphospholipid syndrome, as evidenced by his strongly positive lupus anticoagulant test. So the other thing is, what is the trigger? Is this provoked or unprovoked from pulmonary embolism? Meaning, was there a history of immobilization or surgery? So I don't think badminton is a trigger for pulmonary embolism. You're supposed to be very active and running around the court. But that's all the history we have. So now, if there is underlying lupus anticoagulant, this definitely is, if it's ongoing, then you shouldn't stop, because this is an increased risk of thrombosis due to that problem. However, lupus anticoagulant doesn't remain positive all the time. And then we have to regularly check. When you check for lupus anticoagulant, also you have to stop the warfarin for a washout period, then you can do, otherwise it will interfere with the test. So he had quite long anticoagulation after a year. Then we repeated the lupus anticoagulant, and lo and behold, it's completely negative. And this patient is very well. So what do you do? So I think we do know the thrombotic risk will decrease if the lupus anticoagulant becomes negative. So the tendency is maybe you can say you can stop. But however, and after discussion with Dr. Jia and colleagues, this is an unprovoked PE. So unprovoked PE by itself is a reason to anticoagulate indefinitely. And the argument, if the lupus anticoagulant becomes negative and it's not strong enough to say you should stop anticoagulation, because it could become positive again, and like all autoimmune problems. So probably the advice is to leave it indefinitely, even if the lupus anticoagulant becomes negative. The question is, what would you anticoagulate with? I think I discussed with my colleagues, and most would suggest just carry on the warfarin. Second best would still be a NOAC. But NOACs are not as good if the lupus anticoagulant becomes positive again. So unless you keep on testing, it's best probably just to leave this patient on warfarin indefinitely.
What's your target INR in this group of patients?
Yeah, some used to say about 2 to 3 will do. But if it's really strongly positive, you may range 2.5 to 3.5.
Why does lupus anticoagulant become positive? Do we know?
It can be just primary. It is not associated with lupus.
Yes.
And it's not an anticoagulant, it's a thrombotic thing, because the antiphospholipids target the lining of your blood vessels. So the patients develop thrombosis quite readily. Now, most of the time, you don't find an underlying cause. So it's just a primary autoimmune problem.
So the very fact that this man is antiphospholipid antibody positive, does that mean that he's got this thing forever in him, and therefore he should require anticoagulation for life?
No, it may not be forever. they can become negative. But if he had a provoked pulmonary embolism, say he had recent surgery, we found he had lupus anticoagulant. The lupus anticoagulant becomes negative, and we can actually stop. But this was unprovoked. So even if the lupus anticoagulant is negative, we probably shouldn't stop, because let's say if it is unprovoked and no underlying cause, we will need lifelong anticoagulation. So even if the underlying cause becomes negative, but the fact that this was unprovoked, probably we should leave it lifelong. There's another question. In Slido.
CT contrast.
Yeah, to rule out AVM.
No, there was no CT contrast. I assume you're assuming it is a cerebral AVM. There was no intracerebral bleed, and therefore no CT contrast done to exclude AVM.
Okay. No other questions. None on YouTube. Maybe may comment about, often the question again, maybe you want to summarize again, when should we choose between anticoagulation versus thrombolysis versus thrombectomy? Or
I think that slide
again, I think it's very important to
so we will.
Oh, I think your slide share has disappeared.
Okay, we will go back to slide share, and all right. Slide share. I think I come out of settings. Yes.
Now wait,
slide share.
Maximize it, is it? No, go back to your screen. Yeah.
I think basically we just have to risk stratify the patients. There's one table. There's one table that if you could play it would have showed it very clearly for. So how do we risk stratify? One is by looking at the cardiac biomarkers, the pro-BNP, troponin, hemodynamic instability. These are the important things that we need to look at. So patients low risk, the markers are not elevated. Patient is hemodynamically stable. They can just go on heparin. Patients who are very high risk, the other end of the spectrum, hemodynamic instability, those kind of patients may benefit from systemic thrombolysis.
So how do you define hemodynamic instability? Is this the blood pressure?
Based on the blood pressure, yes. Systolic or less than 90.
90.
Yeah.
More than 15 minutes, a heart rate less than 40 with signs of shock.
Correct.
And RV dysfunction.
And then so you would err on more active treatment.
Yes, systemic thrombolysis, or even if you're talking about catheter-directed therapy, then it has to be thrombectomy more than thrombolytic infusion, because that's going to take some time.
I suppose also it will depend on what the facilities are available to you at your center.
Correct.
If you had both catheter-directed versus IV, which one would you prefer?
I would prefer, if the patient is really unstable, you can't even transport that patient to the cath lab for the procedure, then of course you have to opt for systemic thrombolytic agents, because you can just do it by bedside, of course with monitoring and all that. But if the patient is stable enough for you to transport, you can stabilize the patient, get the anesthetist on board, then I would think that catheter-directed treatment will be better, because you're going to use a lower dosage of thrombolytic agents. It's more directed. You can actually, infuse the thrombolytic agents and monitor the patient.
What will be the cost difference between the two? That will become very relevant nowadays.
Yeah. Well, definitely it's not technology has, just appeared today or yesterday. It's been around for quite some time. So it can be quite costly, because the catheters, the ultrasonic emitters, the medication itself, the thrombolytic agent is quite costly. So as compared to systemic thrombolysis, where it's only the cost of the drug, then definitely catheter-directed therapy is a little more costlier. Yeah.
So number one, to put it in perspective, of course it's a bit more cost. You get a faster resolution of the thrombus and more quick response to the hemodynamics. But when we look at long term in terms of morbidity, mortality, I think none of the studies really showed much difference long term.
What about the risk of pulmonary hypertension, chronic pulmonary hypertension?
No, I don't think so, that was addressed. So no, it has not been shown.
I think that also depends on how early the patient presents.
Not so much in the mode of treatment.
Yeah. Because most of them, you see, after that, if you're talking about little emboli and all that, they will be on anticoagulation after that. So that reduces the chances.
Of course, whether it is a recurrent thing which has been going on or whether it's just a single acute thing.
Okay, yeah, we come to the hour on the dot. So before we proceed with the more important one of CPD points, just a reminder to all those, there's the GP Cardiology Symposium is on next month on the 12th of January 2025 at the Dorset Grand. So this is a physical event, and you are invited to register, and it's free attendance, right?
Yes.
Completely free attendance with how many points? I think
8
CPD points. Yeah. So this QR code is not for yours. It's for the GP Cardiology Symposium next month. All right. So please don't forget to subscribe if you haven't to our channel. And here it is, the moment you're waiting for. This is the QR code for the attendance link for the doctors. Yeah. So let's check if it's working.
You get two. You can get both.
Yeah.
You get this and you get that.
She'll do first, right?
No, that one is the big one.
So
This
the
one you
points will be updated within about 7 working days, yeah, by the SJMC team. Let's see, it's working. Okay.
I got more than enough. So.
Yeah. Kidok, I think it's working. So please do leave. You have any comments and feedback? Also, feel free to leave as a comment to this video. The points, I think we'll get it reflected in the MMA app after about a week. Any problems, please get back to us in docs. After today, we shall try to make it available for claiming points as well. But look at the pinned comment to the video. All right, so thank you all.
Thank you. Have a good weekend.
Have a great
you.
weekend.
Bye-bye.
Yeah.
Thank you very much, everybody.
Yeah.
Thanks a lot.
Okay. Bye-bye. Okay, today without a hitch.